I'm going to talk about IVC dilation and collapse, and the reason that I'm including this in the chapter on central venous pressure is that collapse of the IVC, at least, not so much dilation, but collapse of the IVC is basically a surrogate of your central venous pressure. It's an ultrasonographic JVP assessment is basically what it is, and it's becoming more and more prevalent, this assessment of right atrial pressure using the ultrasound in the intensive care unit because of these small portable ultrasound devices, or SPUDs as we call them, at least that's what we call them at Stanford, these pocket echoes that are more readily available. And it's quick and it's easy, and things in medicine that are quick and easy should usually be interpreted with caution, because as you know, there's nothing quick and easy in medicine. There's no one perfect diagnostic test except maybe autopsy, and even that's not perfect. So I'm frequently seeing in notes things like, ultrasound assessment of the IVC revealed euvolemia or revealed hypervolemia, and that just makes me crazy, because as you've seen, assessment of the right atrial pressure cannot be used as the be-all and end-all for determination of volume status. That requires a clinical exam. You have to, examine the patient, touch the patient, listen to their lungs, look for pitting edema, assess for ascites. And the ultrasonographic assessment of the IVC is basically just a modern day JVP assessment. It doesn't tell you their volume status, it just tells you their central venous pressure. And so we need to talk a little bit exactly about what IVC collapse means and what it doesn't mean, and similarly what IVC dilation means. And they also have some implications for fluid responsiveness, and I'm going to talk a little bit about that first in the context of IVC dilation. So this is what I just talked about, almost verbatim actually. But again, just want to focus on volume status is not defined by any one data point. Okay, it's a gestalt clinical interpretation, and in fact, actually, even studies using radio-labeled albumin as the gold standard for total body volume status. Even then, when you have very experienced cardiologists do the physical exam, we're all very poor at doing a volume status assessment. So it just leaves us kind of in this very uncomfortable situation that's very common in the ICU. I think volume status is one of the most challenging aspects of critical care medicine, and therefore thinking that there's one simple test that's going to give us the answer is very, I think, can be dangerous. So IVC assessment so this is important, IVC assessment may be used to determine volume responsiveness, not volume status, but only under one very specific clinical scenario. And this is the patient population in which this was derived. That is a completely passive, mechanically ventilated patient with a tidal volume of 8 to 12 cc's per kilogram with neither arrhythmia nor spontaneous inspiratory efforts. So how many patients in the ICU are like this? Well, very few, especially this 8 to 12 cc per kilogram parameter with the lung protective ventilation that's been shown in recent meta-analyses to likely be beneficial for all patient populations, not just those with acute lung injury or finding patients with this degree of tidal volume is uncommon. But this is the patient where IVC dilation can be helpful as a marker of volume responsiveness. So what's the physiology here? You have to bear in mind that IVC dilation is a different physiology from IVC collapse. So during a passive, no spontaneous inspiratory efforts, mechanical ventilation, a machine-delivered breath will increase the CVP, as we've kind of already talked about. So you're going to increase the CVP up to here. And actually, as we saw, there's actually changes in the venous return curve with PEEP and mechanical breaths that actually tends to increase the right atrial pressure more. But just for simplicity, I'm showing it moving along a simple systemic venous return curve. And this increase in right atrial pressure causes a momentary increase in IVC volume, and therefore IVC, again, IVC pressure. Oh, sorry about that. My animation is a little bit abnormal there. So let's just look at this. This is the CVP minus the intra-abdominal pressure, because remember, you're looking at the IVC below the diaphragm, so the pressure is going to be influenced by the ambient intra-abdominal pressure as well. So it's when you apply a breath in the thorax, the pressure within the right atrium and the vena cava increases, okay, and the relative increase in CVP to the intra-abdominal pressure causes a large shift in IVC volume if you're on the ascending portion of your IVC volume pressure curve. So this is the like we've already talked about, this is essentially the compliance curve of the IVC, or it is the compliance curve of the IVC. That is a change in volume to a change in pressure. That if you're on this ascending portion, a small change in pressure with the ventilator-induced breath as the CVP goes up more than the intra-abdominal pressure causes a large increase, a dilation of the IVC volume. Okay. In contrast, if the increase in CVP relative to intra-abdominal pressure does not result in a large increase in IVC volume, the IVC is no longer preload responsive. So now you're on the steep portion of your IVC compliance curve, and when you give that little ventilator breath, when you give the ventilator breath, the pressure in the CVP goes from here to here, but you're on the steep portion of the curve, so the volume changes very little. So here the IVC does not dilate very much in response to a passive mechanical breath. And this suggests that the IVC is no longer preload responsive. And as a surrogate, the heart is no longer preload responsive. And this is actually a pretty good marker of true volume responsiveness, that if there is a large dilation again of IVC with a passive mechanical breath, then the patient is very likely to be volume responsive. But again, the patient cannot have any spontaneous inspiratory breaths. They have to be free from arrhythmia, and they have to have a certain tidal volume applied, which is, I think, very uncommon in the ICU. So what about collapse of the IVC? So this is a very different physiology. Well, not very different, but it is not the complete reverse of what we just saw. So assessment of the IVC collapse during spontaneous inspiration is the result of active contraction of the diaphragm, okay, because the patient is spontaneously breathing, therefore by definition they're actively contracting the diaphragm. It's not being passively increased by the ventilator. And this increases transdiaphragmatic pressure. So the decrease in the central venous pressure, which follows, again, as we've already seen in the venous return curve, in the cardiac function curves, the decrease in the CVP follows the decrease in intrathoracic pressure. If you're on the ascending portion of your cardiac function curve, is transmitted to the IVC, and simultaneously with the contraction of the diaphragm, intra-abdominal pressure is increased and supersedes intra-abdominal IVC pressure. And as we talked about in Chapter 2, this is the Starling resistor physiology, and that is when essentially a Starling resistor is when the ambient pressure is above that of the intravascular pressure, and it collapses the pressure of the blood vessel. And this leads to a plateau in flow. It doesn't cease flow because as the vessel collapses, the instant that it collapses, the upstream vascular pressure then supersedes the transmural pressure, and it instantaneously opens and then collapses, then instantaneously opens and collapses. So flow just hits a plateau. It doesn't cease. And then some people call this vascular waterfall, and the waterfall analogy just means that the downstream pressure no longer affects flow. And in this example, the downstream pressure is right atrial pressure. So you can make that once you hit this Starling resistor physiology, you can make that right atrial pressure as low as you want. flow will not increase because the abdominal pressure is causing this fluttering effect of the Starling resistor. Okay, so this area here is the Starling resistor, or the vascular waterfall phenomenon for venous return. So I think maybe 20 years ago in a study of healthy volunteers, they looked at IVC collapse and they correlated it with CVP. And what they found was if there was a greater collapse, then it was an accurate surrogate for a CVP of less than 10 millimeters of mercury. So in this patient, right, they've got a right atrial pressure of less than 10 millimeters of mercury. They take a normal, calm inspiratory breath. The cardiac function curve shifts leftwards, and then it hits this plateau portion. And this is the fluttering effect that you see with the IVC. Okay, so here's that cartoon that I think I've shown in almost all of my chapter lectures. Again, this is the anterior chest wall, the posterior chest wall. This is this patient lying on their back, the diaphragm in orange here, the IVC, the heart, the right atrial pressure. Okay, so this patient takes a deep breath in, or I should say a normal breath in. Right atrial pressure falls in response to the decrease in intrathoracic pressure, and then a gradient occurs down the IVC. This leads to increased blood flow, as we'll see here. Blood flow increases, but then abdominal pressure supersedes intravascular pressure as the diaphragm contracts, and you get this collapsing motion. Okay, so that's what you're seeing with the ultrasound. Now, what about in a patient who's got a higher right atrial pressure? Okay, so their venous, let's say they're a little bit volume loaded and their venous return curve is shifted to the right compared to the first patient. Well, this patient takes the same normal tidal breath in, okay, and what happens? Well, they don't quite get to the vascular waterfall plateau portion. In reality, this is probably a curvilinear transition from linear venous flow to the plateau portion. It's probably more curvilinear. It's not all or none as is depicted in these diagrams. So as you approach this, you get less collapse because the pressure doesn't decrease as much. So in my little cartoon here, you just get like a baby collapse. Okay, and so that is in healthy volunteers with a normal inspiratory efforts and IVC collapse of less than 50%. This was an accurate surrogate for a CVP of more than 10 millimeters of mercury, and it just flows from this physiology that we've talked about ad nauseum. Okay, and then you have to bear in mind that how these numbers were derived. So let's say this patient's hypervolemic, but they have excessive inspiratory effort. You tell them to take a really big deep breath in, okay, and they're on CPAP, okay. So you've shifted the venous return curve as a result of the application of PEEP, as we've already talked about. It shifts the venous return curve to the right. It lowers maximal venous return because, remember, the plateau portion occurs when the pressure within the vessels entering the chest goes below the ambient pressure, that is the intrathoracic pressure, and that occurs more readily with the application of positive pressure because pressure within the thorax goes up, and so collapse of the great veins entering the chest is going to occur kind of at a lower level in terms of blood flow, but the pressure, the so-called P-crit or pressure critical, where the venous return curve plateaus, actually increases from atmospheric pressure here, 0 atmospheric pressure, to a higher pressure with PEEP. Okay, so this is the patient who's got heart failure and they're on CPAP, and then you interrogate their IVC. Well, they're breathing heavily and they've got a lower maximal venous return because of the application of PEEP. Well, what are you going to see? Well, you're actually going to see collapse here. Okay, so this physiology, and you have to understand how this physiology was derived in normal, healthy, probably upright or probably supine volunteers, and how it completely falls apart in patients who have excessive inspiratory efforts, who may have changes in their venous return curve because of the application of mechanical ventilation or positive pressure ventilation. So witnessing the IVC collapse no longer is a surrogate really of central venous pressure. And IVC collapse has been used as an assessment of volume responsiveness in patients who were in the ICU, 40% of whom were assumed to have hypovolemic shock. I think most of them were trauma. And the use of IVC collapse as a determinant of volume responsiveness in these patients really did not play out. It was not very accurate at all. And using IVC collapse during spontaneous inspiration can lead you astray very quickly. So you have to understand the difference between IVC collapse and dilation in terms of volume responsiveness. And as we've already talked about extensively, CVP itself is not a marker of volume status as opposed to volume responsiveness, and that is determined by a good clinical exam and history. So that's it for my talk on the central venous pressure in terms of principles of measurement, determinants of the CVP, the difference between CVP, volume status, and volume responsiveness, the use of dynamic changes in the CVP as a surrogate for, or as a marker of volume responsiveness, how the changes in CVP can occur in different pathological states with the application of mechanical ventilation, and then lastly the ultrasonographic assessment of the IVC, its dilation as a marker of volume responsiveness in passive, completely passive mechanically ventilated patients, and its use as a surrogate of CVP in healthy supine patients with normal inspiratory efforts, and how its physiology really completely falls apart when you have very sick patients whose venous return and cardiac function curves are shifted in response to various disease states. So thank you very much for tuning in, and I hope that you found these lectures very illuminating.